Okay, so the session is being recorded. Welcome everybody to Learning Unit 5, which is on the treatment of abnormal behaviors. So in our last learning unit, we focused on some of the different mental illnesses that people can experience and looked at the causes of some of those and some of the symptoms. And we looked at the DSM-5, how we can identify the symptoms and classify mental disorders. So this module now moves on to treating some of those disorders and the different ways that mental disorders can be treated by various health professionals. So we'll start with what's in our learning unit outline. So our module outline has got the learning outcomes there. So the first learning outcome is to discuss the different treatments for abnormal psychology. The second one is to be able to explain the role of mental health professionals when dealing with abnormal behavior. And the third one is to differentiate between a psychologist and a psychiatrist. And the reason I've put a little star in there is because it only gives you a very short chapter reference for that first learning outcome of discussing different treatments, whereas in fact those treatments are actually expanded on in the next section of the chapter after page 640, which is why I've made a note at the end. And what we'll do in this learning unit is we will discuss those treatments in a bit more detail using the pages from your textbook from page 641 to 658. So in order to be able to understand and discuss the different treatments, you need to move beyond what's on those pages that are referenced and move on to the more comprehensive information that follows from 641 to 658. So that's specifically why I've made that note there, so that you're not confining yourselves just to that short portion of text that's written on pages 637 to 638. Otherwise, you're not going to be able to understand what we mean when we discuss those different treatments. So please make note that you need to move beyond what's mentioned on those pages in the textbook. So a quote from our textbook to start us off is, as a multicultural society, we will only treat abnormal behavior effectively when we are mindful as to how the behavior is viewed from multiple perspectives. So it's important to understand that specifically where we live in South Africa, where we have many different cultures, you can't look at a medical treatment or a treatment for an abnormal behavior from only one perspective. We've got to view it from a number of perspectives in order to treat our client effectively. So just remember that however we look at it, there are influences that are in somebody's own personal circumstances that offer guidance as to how a particular mental illness can be treated. And it's important we always remember that we need to view behavior from multiple perspectives, not just from one. So when we start right at the beginning, treating psychological disorders, that is a process called psychotherapy. So what psychotherapy does is when we treat a disorder from a psychological perspective, we really do look at the etiology or the causation, what is causing those disorders in order to enable effective treatment. And treatment is guided by a treatment protocol, which is a specific approach that a health professional has to treating and managing a specific disorder. And those treatment protocols have been developed, they've been evaluated, they've been tested, they've been implemented over a period of time on specific relevant sectors of society. So it's not something that's just randomly thought of by a psychologist as a way to treat someone presenting with symptoms. There actually are specific treatment protocols and approaches to treatment that have been tried and tested, evaluated, and developed over time. And so what that means is that as well as that, it's quite a circular process, and the clinician needs to look at identifying and modifying and implementing supported treatment regimes and to reflect on how well they're working, and if adjustments need to be made to certain treatment protocols, then they need to be implemented. So a treatment protocol is very specific. It's not just made up as we go along. It requires a lot of time, a lot of research, a lot of understanding of various approaches and various theories in order to develop specific treatment protocols. And the model, Lou, it might just be on your side. Is anybody else battling with sound? All good, Sasha. Lou, it might be on your side. Okay, great. Thank you. So we discussed in other modules about the biopsychosocial model, and this is where we talk about multiple perspectives. And the biopsychosocial model facilitates an integrative approach to the causation or etiology of mental illness, to be able to understand its complexity. So we know this is where it talks about the different perspectives, is that we can't just consider mental illness from one perspective, its causation being from one area. You need to look at multiple perspectives, and the biopsychosocial model says to us we need to look at the biological component, we need to look at the social component, and we need to look at the psychological component in order to actually understand mental illness and mental health. And the biopsychosocial model also gives us an objective for treating, that when we treat something, we don't always just look at one dimension of treatment. It could be a multifaceted approach to treatment. And so when we say that, it actually means that there could be a team of people working on somebody who's suffering from a mental illness, specifically in a clinical or psychiatric session, is that as much as the illness, we have to look at the causation from multiple perspectives. Often we have to look at the treatment from multiple perspectives as well, hence the multidisciplinary team. So the biological dimension is all of those physiological factors. It's the genetics. There could be a genetic influence. There could be biochemical influence to do with neurotransmitters in the brain. There could be a physiological influence like brain structure, which speaks to our physical well-being, our hereditary, which is our genes, and physical disabilities. The psychological dimension looks at the psychological well-being of somebody. It looks at their self-esteem, maybe coping strategies, their social competencies. And the social dimension looks at the family and personal relationships. It maybe looks at the educational system, looks at interpersonal relationships, beliefs, the cultural aspect. So all of those different systems make up the framework of mental health. And we looked at that in the causation. When we looked at what causes mental disorders, in some mental disorders, there can be a biological cause, a psychological cause, or a social cause. And it's those three things looked at in conjunction with each other that gives a full understanding of what's causing the disorders. And again, when we treat it, we also look at treatment in a number of dimensions as well to provide that complete process of treatment for somebody who's suffering from mental disorders. So is everyone clear on what the biopsychosocial model is? It speaks to those multiple perspectives in causation, etiology, as well as treatment. So we've covered that one a couple of times, so I hope that that is clear. So when we look at treatment, you've got a client or somebody who presents you with a problem or a chief complaint. So the problem is going to be the actual symptoms. It's the manifestation of the problem. How is it being experienced? What are the symptoms that are being seen or described? And it's also very subjective. It's also a person's account of their experiences. So the client presents with a chief complaint, so that would be the symptoms that could be being experienced, as well as their own account of their experiences. And the first thing the clinician does is they have to gather as much information as possible about the individual and even their families. They need to get like a case history maybe do some testing, some psychometric testing, but they need to look at the biological, the psychological, and the psychosocial functioning of that client, which gives them that biopsychosocial approach to looking at gathering information to create a complete picture of the client that they will be working with. And from that, the client provides a working diagnosis. The clinician, provides a working diagnosis. So to do that, they use various diagnostic tools, which can be different questionnaires, psychometric testing. It could be looking at symptoms in their classification categories. And they do that to provide the diagnosis once they've got all the information that is needed. And from that, they make use of a treatment method. So there are different ways to treat mental illness, and we will cover those during the course of this module. One approach is insight therapies, one approach could be behavior therapies, and the third approach is psychopharmacology, which we will elaborate on in further slides. So once they've gathered all of that information together using all the various tools at their disposal, they can make a diagnosis. And making the diagnosis means that they now have an understanding of the current medical condition. They've made use of their diagnostic tools, and they've made use of objective observations that they've got, that they've seen seen behaviors, they've spoken to people, they've got subjective accounts of what is being experienced by the client, they've done diagnostic inquiries, and they also make use of collateral information, which is additional information they can gather, such as the age of the client, the sex of the client, the socioeconomic circumstances of the client. That's all the collateral information they can gather. So they have a complete, almost like a history of the client before they start to work with them. So that's how they go about gathering that information in order to make a diagnosis. So when we look in the mental health professional field, we have got psychologists and we've got psychiatrists. And there's a very big difference between the two. A psychologist is somebody who deals with the psychosocial well-being of the individual. To become a psychologist, you do what you're doing now. You do an undergrad degree. This is if you want to become, for example, a clinical psychologist. You do your undergrad degree, you do your honors, you have to do your master's, and you have to do an internship. And to become a clinical psychologist, you need to also complete community service. Other kinds of psychologists, such as an educational psychologist and an industrial psychologist and other branches of psychology, you still do the undergrad degree, you do your honors, and you do your master's and your internship, but you don't need to do the community service component. So all in all, to become a psychologist, it would take you 3 years for your undergrad, a year for your honors, maybe a year or 2 for your master's, your internship. You're looking about a 7 or 8 year process to actually get to a point to be a clinical psychologist. A psychiatrist is very different. A psychiatrist is a medical practitioner, somebody who's actually done their degree in medicine. So they are a physician who has then gone on to specialize after they've completed their medical degree. They've gone in to specialize in mental health and mental disorders, and specifically they deal with severe mental disorders. And a psychiatrist is usually the person who deals with that pharmacological intervention, the prescribing of the drugs, the treatment regimes for drug use to treat abnormal behavior. So there's a very big difference between a psychologist and a psychiatrist. Often the two work together. A psychologist would refer a client to a psychiatrist for further treatment, especially around the neurobiological issues, but the two differences are there between the psychologist and the psychiatrist, but generally they work together. Also within our mental health profession, you have people who are not doing the same qualifications. Their roles are different. You have psychiatric nurses. They work in mainly hospitals and do inpatient treatment. You've got counselors who promote psychological well-being in many settings, whether it's in schools or in the nonprofit sector or in community health centers. You can have counselors. You've got social workers who are people qualified in psychosocial healthcare, and you even have occupational therapists who deal with helping people suffering from mental disorders cope and survive in various different environments. So within our healthcare system, specifically within mental health, there are a number of professional routes that can be taken. If you want to be a registered counsellor, you have to do your undergrad degree and you have to do your honours degree, and then you can go the route of doing your honours in counselling psychology, and then you have to do your internship, and then you can register as a counsellor. Again, you have to do that internship, because that's where the practical experience takes place. And all of those professions have to be registered with the Health Professions Council of South Africa. So in order to do that, you have to meet certain requirements. It's not the college that's registered with the HPCSA, it's the individual who registers after they've completed the relevant studies. So once you've completed your undergrad and postgrad qualifications and done your internship, you would register with the HPCSA. I don't think Varsity College, they do their honours, but I don't know if they do masters in psychology, but you need to just have a look and see. I'm not sure what their learning pathway is, but it's just showing you that there are multiple ways or multiple careers in mental health. So if you don't become a clinical psychologist, you could do industrial or educational, or whichever field appeals to you, and they're all quite different and they all work in different settings. Okay, so that's just showing what there is, the different healthcare professionals, as well as the difference between a psychologist and a psychiatrist, but often they work together as part of that multidisciplinary team to treat somebody. So the first type of treatment that we're going to look at is called insight therapies. Okay, and we're going to go back a little bit and touch on some of those theorists who we learned about in earlier modules and even last semester, who work in the field of insight therapy, so that we can understand what insight therapy is. And insight therapy is exactly what it says. It's about getting inside somebody to gain insight. Insight therapies involve verbal interactions which intend to enhance clients' self-knowledge and thus promote healthful changes in personality and behavior. So it's going into somebody's understanding of themselves, and through talking to them through verbal interactions, okay, you start to understand what their problems are. And the very first insight therapist that we learned about was Freud, very much a kind of talk therapy. And the original insight therapy was psychoanalysis, which was developed by Freud all of those years ago. And to appreciate the logic of psychoanalysis, we have to look at Freud's thinking about the roots of mental disorders. So remember, we said that in order to treat something, we have to understand what causes it. And so Freud had his own ideas and his own theories about what the roots of mental disorders were. And he mainly treated disorders that people were dominated by anxiety, okay, called neuroses. And he said that neurotic problems or neuroses are caused by those unconscious conflicts left over from early childhood. You should remember this. The battle that happens between the id, the ego, and the superego, usually over sexual and aggressive impulses. And he spoke very much about people have defense mechanisms to avoid confronting the conflicts that take place between the id, the intrapsychic conflict of the id, the ego, and the superego. But he said that defenses only tend to be partially successful, leaving neurotic individuals troubled by anxiety and guilt. So the role of the therapist from Freud's perspective and treating from an insight perspective is to probe into the unconscious of the person to discover these unresolved conflicts. So that intrapsychic conflict between the id and the ego and the superego led to anxiety, and then somebody, in order to cope with that, would have some kind of defense mechanism to cope. So the process of psychoanalysis was the very first theory or process that started to treat mental disorders from a talk perspective, getting into somebody's unconscious. And he probed the unconscious. So remember, we have a consciousness and a pre-consciousness and an unconsciousness. And his anxiety was coming from that unconscious place, and the idea of talk therapy was to uncover it. And so how did he do that? How did he do his therapy? He used a process called free association. And in the process of probing into the unconscious for free association, he encouraged people to express their thoughts and feelings exactly as they occur, with little censorship as possible, regardless of how trivial, silly, or embarrassing their thoughts might be. And they basically studied what was coming out through that process of free association to get an understanding of what is going on in the client's unconscious. And he also used the process of dream analysis. So he asked people to analyze their dreams and to describe their dreams in therapy, and he analyzed the symbolism in dreams to interpret their meanings. So that's what insight therapy is. It's trying to raise stuff from the unconscious into the conscious awareness of people so that they can talk about it, and through talking about it, they actually start to feel better about it. And that was the process that he used. So one of the ways that he did that was through interpretation. And therapists' ability, what that is the therapist's ability to explain the inner significance of clients' thoughts, memories, feelings, and behavior. So after listening to somebody and what they're saying, what they're interpreting, the therapist helps to offer interpretations of that the client themselves can't understand, but with the intervention of the therapist, interpretations can be offered so that understanding can be reached. One of the things that were also experienced was resistance. And basically resistance is a psychic apparatus that keeps things out of our awareness. It's our unconscious defense mechanism, because people don't want to face up to painful things that are buried in their unconscious. So resistance can be shown in many ways. The patient could be late for treatment. They could show hostility towards the therapist, that they're very resistant towards treatment. And there's also a process involved in therapy that could happen, is called transference, where the client unconsciously starts relating to their therapist in ways that mimic critical relationships in their lives. So often you can use a process of reenactment with a client, which would help them bring forward those things that are repressed and conflicts to the surface. So those are things that in therapy the therapist looks for, or Freud looked for in the process of psychoanalysis, to start to help the client bring those things to conscious awareness. So psychodynamic therapies, which still use interpretation, resistance, and transference, what they do is they focus on emotional experiences. They explore efforts to avoid distressing thoughts and feelings. They look at identification of recurring patterns in patients' life experiences. They discuss past experiences and events that happened during their childhood. They do an analysis of interpersonal relationships, a focus on the therapeutic relationship itself, and they explore dreams and other aspects of fantasy life. And all of those things form part of the treatment of insight therapy. It's getting to understand what is in the unconscious of the person through talking and bringing things to conscious awareness, where sometimes people feel better just by speaking about the problem. And once you bring those up to conscious awareness, once people speak about them, the problems themselves start to be resolved. So the other form of insight therapy that is discussed is client-centered therapy. So Freud very much went into the unconscious of the person, whereas where we look at client-centered therapy, it's a different perspective. It's used by Carl Rogers, was the theorist who was a humanist, and he developed client-centered therapy, which is again a type of insight therapy, but it's not so much about probing the unconscious. It's about setting a supportive client-centered relationship and an emotional climate, and the client themselves play a major role in determining how that therapy proceeds. So client-centered therapists basically help clients to realize that they do not have to worry about pleasing others and winning acceptance. And they encourage clients to respect their own feelings and values. And they help people restructure their self-concept. So that's very much what it's about. It's about achieving congruence with your self-concept. And so how you see yourself, and how you see how you think others perceive you. You have your ideal self and a perceived self, and the difference between the two is incongruent, and that is where mental illness occurs, is that there's an incongruence between how you see yourself and how you perceive others to see you. So what Freud does is, according to not Freud, Carl Rogers, incongruence makes people feel threatened by realistic feedback about themselves, which leads to anxiety. So it's that difference between your ideal self and your perceived self that causes anxiety. And it's that anxiety that results in defensive behavior that you use to protect yourself from inaccurate self-concept. Hence, client-centered therapists try to help clients restructure their self-concept, how we see ourselves, to correspond better to reality, and thereby reducing the anxiety. So it's very much dealing with the client in the present space rather than digging into the unconscious. So they help clients realize they don't have to gain acceptance from pleasing others, and they encourage clients to respect their own feelings and restructure their self-concept to correspond with reality. So somebody who is suffering from the incongruence between the ideal self and the perceived self basically believes that affection from others is conditional, and they need to distort those shortcomings to feel worthy of affection. And then they have a relatively incongruent self-concept, which leads to recurring anxiety. And from that, they have defensive behaviors, which they use to protect themselves from inaccurate self-concept. So it's very much a cyclical thing. And once that anxiety is there, then you engage in the defensive behaviors, and then you're encouraging the incongruent self-concept, and it's a very hard cycle to break. So the goal of it, the goal of client-centered therapy, is to encourage somebody to become self-accepting of yourself in order for personal growth to take place. And it's very important that it's a relationship between the psychologist or the health professional and the client, that it needs to be conducted in an environment where the client feels safe and the client feels accepted. And so it's very different to Freud's therapy that was very much about talk therapy. This is about actually getting somebody to start to believe in themselves and their own self-worth. So Rogers held that there are three main elements to creating this atmosphere. And again, this is the therapist, the role the therapist plays in this therapeutic process is genuineness, or the therapist being completely honest and spontaneous with the client. The therapist must hold the client in unconditional positive regard, which means they're non-judgmental of the client. They accept the client as a person, and this is what the client is experiencing, and that is what we are working with. And they have to be empathetic. So the client and the therapist work together as equals, with the therapist almost acting like a mirror. And as people speak, you ask for clarification to make people more comfortable with their genuine selves, and basically to reconstruct their personality and to promote their own self-worth and self-image and reduce that anxiety. So those are two approaches to insight therapy that help you understand what that actually means as a term. Now, other kinds of insight therapy that can happen is group therapy. And that's where a group of people get together. It's not a client and one person, it's a group of people where group members often work together to assist each other in their treatment. And the role of the therapist in that group is to make sure that the people in the group are all similar. Okay, there's nobody in the group who's going to create disharmony, and the therapist facilitates that process and prevents anything harmful from happening in the group. And it's often a cheaper way of doing it because you're dealing with multiple people at one time. So often a group therapy session adds a different dimension around insight from other people, as well as it can be cost effective. Couples and family therapy, that's very much focused on gaining insight into relationship issues, whether it's between you and a partner or between family members, and seeking to understand what are those entrenched patterns and integrations that cause distress. So dealing with families as a system, your relationship in a family with various family members all working together. And it's about enhancing communication, building tolerance, flexibility, and problem solving. And positive psychology is a relatively new area of psychology, but again, it focuses on health and resilience and well-being, looking at strengths and positive emotions. So it's about well-being therapy. So remember, we spoke about stress and how to cope with stress or to prepare ourselves for stress. And it's about promoting a healthy psychological well-being in people so that they can cope with situations. So that is an oversight of what insight therapy is. And I hope that's given a clear picture. Insight therapies, in terms of their effectiveness, it's better, what the textbook says, which is supported by research, is it's superior to having no treatment at all. So insight therapy is better than nothing for sure. And the effects are reasonably durable. Okay, so that means they might not change somebody forever, but they are able to change people for a while. But again, none of these processes might require recurring sessions with therapists. It's pretty similar. It shows equal efficacy, which means effectiveness. So when you compare it to drug therapies, for example, it can show effectiveness in treatment, although most of the improvements happen in the early stages of treatment, and the improvement diminishes over time. So you see a significant improvement maybe after 4 or 5 sessions, sort of a leap and a bound, but the actual gains and improvement diminish over time. So it's a kind of treatment therapy. It shows effectiveness. Obviously, different people have different approaches to therapy, and you would choose whether you had an insight approach to therapy. Psychoanalysis is sort of not really used as much now as something like client-centered therapy, which is a far more popular form of therapy for helping people with anxiety and self-image and various things like that. So the next type of therapy that happens alongside insight therapy as a second type is a behavior therapy. So we learned about behavior and learning about learned behaviors through conditioning, classical conditioning, and operant conditioning. So what behavior therapy does is it takes those same principles that we discussed when we discussed how learning takes place. It takes the same principles to try and change a client's maladaptive behaviors. So the personal insights are not necessary to produce change. You rather look at what the symptoms of the problem are. So behavior therapy is basically based on 2 key things. First, it's assumed that all behavior is a product of learning. No matter how self-defeating or pathological a client's behavior might be, the behaviorist believes that it's a result of past learning and conditioning. So every maladaptive behavior is a learned behavior from one way or another. And second, it's assumed that if a behavior can be learned, the way to treat a behavior is to unlearn the behavior in exactly the same way. Through classical and operant conditioning, people can unlearn behaviors. So the behavior therapist attempts to change clients' behavior by applying the principles of classical conditioning, operant conditioning, as well as observational learning. in a therapy process. So what they're trying to do is to say, what we're interested in is changing the maladaptive behavior by helping somebody unlearn it. So the ways they can do that, the ways they can treat people, they use, if we look at somebody with phobias or fears, they reduce those phobias or fears and anxieties that are produced through those phobias and fears to things like counter conditioning. So that means opposite conditioning. It means unlearning. So as much as something's been conditioned into our learning, we're trying to now counter condition it. So one of the treatment approaches for this is what's called systematic desensitization. So that assumes that most anxiety responses are acquired through classical conditioning. So remember, we learned about classical conditioning, where a harmless stimulus has been paired with a fear-arousing event so that it becomes conditioned to induce anxiety in us. What we're trying to do is to weaken that association between that harmless stimulus that was paired with a fear-arousing event, and we're trying to weaken that association so that the anxiety is reduced and the fear is reduced. So if I say to you, for example, in recent rain, my car aquaplaned and skidded off the road. Now, when it rains, I'm very anxious about driving. So if I see the sky darken and I think a storm is coming, I think I'm now terrified of driving. I either need to stay where I am or leave and get home as quickly as possible before the rain happens. But now I have got an anxiety about driving in the rain. Okay, so they would desensitize me. They would reduce that fear. And there's 4 steps of systematic desensitization. Basically, the therapist will get you to relax, so that you're releasing all the tension in your body and your breathing is reduced, and your breathing, you start to breathe deeply and focus on your breathing. And then basically what they do is there's a hierarchy of the patient's fears that are constructed. So what are all of your fears? And it ranges from the imagined scenes to arouse mild anxiety to those that arouse real fear or intense fear. So you have a hierarchy of fears. And then basically what the therapist does is the desensitization process. As the patient relaxes, the therapists vividly begins, the patient relaxes, vividly imagines fear-arousing scenes, starting with those that are only mildly anxiety-producing. So you start with a very mild fear, and you basically present images or scenes that reflect that, and then you get the client to confront those fears, okay, beginning with the milder ones. So you're basically systematically desensitizing them to a fear. And in a modern treatment now, with things like virtual reality, you can actually even present those visual images to somebody through some kind of 3D image, like you can see in the picture that I put there. So that's about systematically desensitizing somebody to cope with a fear-arousing anxiety. Exposure therapy, again, is another kind of treatment where you actually give people direct exposure to anxiety-arousing situations in controlled sessions. So that is a process by which people can reduce their anxieties and those behaviors that are as a result of the anxiety. Another way behavior training can happen, remember we spoke about modeling, about watching how other people behave. So there can be social skills training, which are also acquired through learning. So social anxiety or social ineptitude contribute to worsening feelings of anxiety and inferiority. So a kind of behavior therapy, it could be a therapy that emphasizes modeling, watching other people who we consider socially skilled, whether they're friends or peers, but trying to remodel our behavior through watching others. We could do role-playing exercises using rehearsal, and also we can reshape behavior. So we can gradually change behavior. If we think about, it's about delivering reinforcement. So you're starting to deliver positive reinforcement in a stepwise way to gradually shape somebody's behavior. So it's a little bit like the picture on the left is a little bit like training a dog to do a trick. You start gradually, you build up with the small thing until you actually get to the overall result that you're looking for. It's called shaping. So cognitive behavioral treatment is another way of dealing with anxiety. And we remember that when we look at our model of mental illness, our thinking, our cognitive factors play a key role in anxiety and mood disorders. So it's really important then to look at people's thinking patterns and therapy to try and change people's thinking patterns in order to reduce anxiety and help with mood disorders, which is really a combination of verbal interventions, which is talking, as well as behavioral modification techniques. So cognitive behavioral treatments are called CBT, and it's basically you take somebody and you're starting to work with somebody who's got a real negative way of thinking. They could really, you see it when somebody suffers from depression, a negative way of thinking. So the goal of therapy is to change those negative thoughts and maladaptive behaviors. So somebody could have negative views about the world, combined with negative views about the future, negative views about themselves. And we spoke about that when we were looking at depression. It's the cognitive component of depression. It's that negative view of the world. And so what therapy does is it tries to then help people detect those negative thoughts. So how we think, how we feel, and how we act in a negative way. It works through a process of really testing those thoughts so that the client can see how unrealistically negative they are, and then using modeling and systematic monitoring of own behaviors, as well as behavior reversal, we try to change those behaviors. So it's very much dealing with how our thoughts, behaviors, and emotions are intertwined, and it's about getting people to identify negative thoughts, to test the thoughts, and then to try and change their way of thinking through various methods. So that is what cognitive behavioral therapy is. So if we had to look at the two, we had to look at insight therapies. So insight therapies, the clients, like we explained, clients gain insight or awareness into the reasons for their negative feelings. So they're going deep inside to their unconscious. Behavior therapy helps clients eliminate destructive behaviors that cause negative feelings and instead cultivate healthy behaviors that lead to happiness and satisfaction. Very much behavior-based. Insight therapy is very much non-directive. The client does most of the talking, whereas behavior therapy is very much controlled by the therapist. It's more direct. There's a reciprocal relationship where the therapist poses questions and offers guidance, more guidance than in insight therapy. And the therapist tries to change unhealthy, harmful, or negative behaviors. So in insight therapist, the therapist wants to get to the root of the problem, that unconscious place where all of those negative concepts are held. And in behavioral therapy, the therapist doesn't focus on the cause of behavior, but is more focused on changing the behavior so the person can lead a functional life. So in insight therapy, they treat those pathological symptoms as signs of the underlying problem, whereas in behavior therapy, we look at the symptoms as the problem, and that is what we are trying to address. So those are the differences between those two kinds of therapies, and it's important you can understand those approaches. So the third and final approach, well, the effectiveness, firstly, let's just touch on the effectiveness of behavioral treatments, and it shows that favorable evidence of the effectiveness of most widely used behavioral interventions. Don't make global assumptions about effectiveness, because there's many different wide-ranging nature of behavioral therapies, and for the reasons they're all designed for specific purposes. So you can see that there's multiple ways to deal with behavior therapy, so we can't make wide-ranging assumptions, but basically there is favorable evidence that there are effective ways of treating mental illness, especially mental illnesses caused by things like anxiety, helping people deal with depression, changing people's behaviors and their way of thinking. And the third method of treatment that we touch on is psychopharmacology. So that is about the treatment of mental disorders with medication. It's about taking the pill, the medication, or even electroconvulsive shock therapy. So drug therapy to treat a psychological mental illness through drug therapy or through electroconvulsive shock therapy. So it's very much a physiological intervention, and it's aimed at reducing the symptoms. And it's assumed, it's based on that psychological disorders in part, because remember when we looked at the causation, the etiology, that there are biomedical reasons for disorders, that disorders in part are caused by chemical imbalances. So if you're treating somebody with depression, it might get to a point through using a behavior therapy technique that the person is not making the gains that are necessary. It might be then necessary to move on to some kind of pharmacological treatment that can help to address those chemical imbalances. So it's very much focusing on the biological complexity of psychiatric disorders. And that's where somebody who is a psychiatrist comes on board, because they've got that medical knowledge, that physiological knowledge, and they know how to treat disorders from this perspective. And this is where you see the relationship between a psychologist and a psychiatrist, how the two can work together. So when we look at the different types of medication, we have anti-anxiety medication. And so remember, anxiety becomes, when anxiety is sort of diagnosed, when it gets to a point where anxiety becomes disabling, that people can't function on a day-to-day basis, that is where medication, when a psychologist is battling to get somebody somebody's anxiety levels to drop, it might say, then you need to go onto medication. I'll refer you to a psychiatrist. And that is where a psychiatrist could prescribe something called benzodiazepines, which are also known as tranquilizers. Okay, so that's the psychopharmacological intervention. And what those drugs do, those tranquilizers, those benzodiazepines, is they decrease the anxiety symptoms, and they basically increase sedation levels and help muscles relax. And the reason that they are effective in treatment, it works on neurotransmitters in our brain. GABA is the most common neurotransmitter in the central nervous system, which is found in high concentrations in our cortex and our limbic system, if we remember that. And so basically what GABA does is GABA is inhibitory in nature, so it reduces the excitability of the neurons, specifically those involved with anxiety and arousal. So GABA produces a calming effect on the brain. That's what it does. So some benzodiazepines or tranquilizers act on your brain and body for longer than others, and drugs have what they call a half-life, and a half-life really tells us whether it's a short-acting drug over like an 8-hour period of time, or whether it's a longer-lasting drug over a long period of time. So you get some anti-anxiety medications that are short-acting, have a shorter half-life. This means the drugs are processed in your system quickly. But then if you take those, there's a higher risk of withdrawal. So whenever somebody prescribes something, it's really important to look at what the longer term consequences are, as well as the issues of withdrawal. And longer acting benzodiazepines or tranquilizers have that longer half-life, which means that they're processed by your body slowly, and that's where you're more likely to experience a hangover effect when taking the drugs, but you're less likely to have withdrawal problems. So it's quite, when a psychiatrist prescribes medication like this, it's really important to look at the different drugs that are available on the market and the different side effects of each drug, because people will also experience side effects differently. So that's why there has to be this medical knowledge and understanding of pharmacy. Antipsychotics is another kind of medication that's used or prescribed specifically in schizophrenia and other psychotic disorders. So we know what it does is it reduces those symptoms. So if we say that symptoms of schizophrenia are hyperactivity, mental confusion, hallucinations, and delusions, what antipsychotics do is they reduce the symptoms. They're not going to cure somebody, but the aim is to reduce symptoms in people so they can start to live sort of a functional life, depending on how severe their mental illness is. So antipsychotic drugs, we have the older ones, the typical antipsychotics, what they call them, and we've got newer atypical antipsychotics. And both work for different people, but in this instance, it's really important to look at the side effects that can occur as to which drug is selected. So if the psychiatrist prescribes a first-generation antipsychotic, that can cause, as much as you've got somebody who's suffering schizophrenia, the drug itself can cause severe movement disorders, such as tremors, which can be a bit like Parkinson's. It could be about your muscles going rigid so you can't move, and they're more likely to make you drowsy. Whereas if somebody prescribes you a second generation, it causes less severe movement disorders, but is more likely to include things like weight gain and changes to your blood sugar levels. So it's really important when these antipsychotic medications are prescribed that we understand that they don't necessarily cure mental illness, but they do help reduce symptoms. But in doing so, they can bring along severe side effects in the person who's taking them. So again, that is why a multidisciplinary team is necessary, because again, with someone like with schizophrenia, you might need to bring an occupational therapist on board to help the person cope in various environments in which they find themselves. The side effects that are experienced depend on the dosage and responsiveness. About 70% of cases respond, but remember, when you treat somebody with drugs, it doesn't happen overnight. Okay, there's usually a period where the body has to adapt to the medication. So usually after about 3 weeks, somebody could start to see a difference in the symptoms of schizophrenia through the use of antipsychotic medication. Antidepressants, that's a word that we hear all the time, and you know, it's a very common prescription for dealing with depression, and the aim is that it's used to improve that depressed mood that somebody experiences. So like I said to you, where a psychologist is using a treatment therapy like behavioral therapy to try and help somebody overcome depression, it might get to a point where they actually need to go on to antidepressants. And so what that does, if you look at the picture, it might bring back memories from where we looked at the biology of psychology, and antidepressants deal with the selective serotonin reuptake inhibitors. So serotonin is a neurotransmitter in our body, and the role of that neurotransmitter is to help us feel good. It's to help our well-being, and it raises our mood. It helps us sleep better. It helps our energy levels, and it also aids in our digestion. So what happens is the antidepressants prevent those serotonin neurotransmitters from being reabsorbed into the neuron. Okay, so what we want to try and do is we want to try and block the serotonin from re-entering the cell as part of that reuptake process, and we want to try and keep the serotonin in our body so that our mood is enhanced and our well-being is enhanced. So that way, there's enough serotonin that can stay in the brain and can carry out that function of mood lifting. So serotonin reuptake inhibitors are used to treat mild to moderate depression. As with other antidepressants, a noticeable effect on mood is only after a couple of weeks. So if somebody puts you on antidepressant, it's not going to happen overnight. Okay, like with any kind of drug intervention, it takes time to develop effectiveness. Sometimes, again, when you introduce a new drug regime, and specifically it's been seen with serotonin, is with antidepressants, is in the first week or two, you can actually have a side effect because now you've got an excess of serotonin. So often in the first week or so of treatment, people might start to feel more anxious because their body is starting to adapt to the drug treatment. So all of these things need to be taken into account when we consider drug intervention. So mood stabilizers, if somebody has got bipolar disorder, and so mood stabilizers are used to treat things like bipolar disorder, and it helps reduce the mood swings. And people with both depressive and manic or psychotic problems often come to rely on this kind of medication. It's mainly, the medication itself is lithium. So it's often prescribed to prevent problems after the first psychiatric episode or crisis, and really to prevent it happening again. And once somebody goes onto lithium, basically long-term use of the medication is prescribed. It's going to help somebody's mood. And the problem with something like lithium is when you put somebody on a mood stabilizer and they start to feel better, they tend to stop taking the mood stabilizer. But something like lithium is really, it's part of a long-term medical regime that needs to happen. So again, too much lithium in the blood can lead to lithium poisoning. So again, it's a side effect, and that needs to have immediate action. And newer alternatives to lithium are being developed. So drug treatments are continually under trial, and they're trying to find a drug that actually will not have as many side effects as lithium, and one of those is called valproate. Okay, so that's another kind of drug treatment that can be used. And the final part of drug treatment is what's called electroconvulsive shock therapy. And that's basically where you're trying to stimulate the brain into action. So you produce basically a seizure in a patient, who then has convulsions. So you're reigniting neural networks in the brain. So in order to do that, the person has to be relaxed. And then electrodes applied onto either side of their heads on their temporal regions. And basically, there's an electroshock that is initiated, which increases the nerve activity in the patient's brain. And obviously, it's quite controversial. And as more effective sort of oral drug treatments arose, electroconvulsive shock therapy is now not used as much, in fact, very little, but it is used where the severe, where you've got depression that's not responding to a drug regime. Then electroconvulsive shock therapy could be a final step in trying to circumvent that problem. Overall, evidence-wise, there's enough favorable evidence to justify conservative use in treating patients who are suffering from severe mood disorders and who aren't responding. So it's almost like it's a last resort kind of treatment with patients who aren't responding to other kinds of medication. So those are the ways in which abnormal behaviors can be treated. I hope that that's given you an insight into how treatment can take place and the various ways that it can be done. As you can see, it really does require an understanding of a biopsychosocial perspective, both in the causation of the mental illness as well as in the treatment of the mental illness, and the different ways that it can be treated. Does anyone have any questions? Or is that all good? It is a very interesting subject, and we don't really go into as much depth as we should, but it's a very big area, and I really suggest that you do additional research in those areas that interest you, because it's when you focus in on this, it's where you start to get an idea of where psychology can go. It's sort of really getting a feeling for the discipline as a practicing psychologist, but that's an area you're interested in. So yeah, there'll be a lot of crossover, and I think it's also why it's good to have those subjects together, especially from the social psychology perspective as well. There is a lot of crossover between the disciplines, so they support each other. It's interesting. Right, guys, that's it. I am now going to go and mark your assignments. Good, I'm glad. I haven't seen the sociology assignment, but if it helps, just remember to reference it correctly, not from my slides, but from the textbook. So yeah, so just when you look at those learning outcomes, please make sure you understand those therapies. Yeah, okay, so that Engel is a reference from your sociology, I assume. Okay, there we go. All right, guys, have a good evening. And in 2 weeks' time, I'll see you for your final learning units. But in the meantime, yeah, no ICE tasks are due now. You can just focus in on understanding the material, which is great. Thanks, everybody.